thank you so much for joining our session today. We definitely want to thank our partners at the NJAAP. We've got an amazing session for you today. Our topic is Beyond the Birthmark, a detailed review of vascular anomalies. And I'm sure all of you in your practices take care of children who have common birthmarks like port wine stains. Our speakers today really delve into the management and the need to consider a consultation for the more intricate AV malformations. So we've got a clinic and a program at Hovnanian Children's Hospital, the Megan Sheldman Vascular Anomalies Clinic. And our speakers today are leaders in pediatric healthcare in New Jersey. Dr. Mark Caden is the chief of pediatric surgery at Hovnanian Children's Hospital. He's had a number of really dramatic changes to the program, and he's actually helped us now achieve a level 1 trauma designation at the hospital. So definitely look forward to his leadership with vascular anomalies. Dr. Jessica Skirbo is the interim chair of pediatrics at Hovnanian Children's Hospital, and she's also the division chief of pediatric hematology oncology at the hospital as well. So it's a exceptional treat for today. The recording, the session is going to be recorded, and you will all get the link after the session today. So really excited. And with that, Mark and Jessica, I'm going to turn this over to you.
Thank you, Dr. Paul. We really appreciate all of your support in the development of this very important program. As we get into the details, we're going to talk about not only a review of the anomalies, but the importance of a multidisciplinary approach, and really what's been the crux of our success in that clinic, having all of those teams working together for this very vulnerable population. So for today, we are going to work on decoding vascular anomalies. They certainly may be difficult to tell one from the other. Again, the multidisciplinary approach with reviewing the benefits of that coordinated care and talking about some cutting edge treatments that are becoming more optional for patients with these diagnoses. So what is a vascular anomaly? It's sort of that umbrella statement of a wide varieties of pathology that includes tumors, but also vascular malformations. We know that vascular malformations are really errors that occur during embryogenesis, either presenting immediately at or shortly near birth, where they're malformed vessels without any type of cell proliferation. They are relatively common, but they are still presenting challenges, which leads to frustration and fear for the patients as well as their caregivers. And the two main obstacles that we see are A, standardizing the name, understanding the diagnosis by name, but also which division do we go to? Where should they best be seen to care for the complexity of these cases? And we truly feel and can demonstrate that a multidisciplinary approach is essential. So from a classification standpoint, as early as 1982, we had the International Society for the Study of Vascular Anomalies that classified them in those two main categories, malformations versus tumors. We've now tried to delve even further, starting to differentiate them by the rate of flow from high and low flow, and then the vessel that's most affected. And that's really helped tremendously. More recently, now we're adding things like genetic mutations to lead to causality, more detailed descriptions of the lesions, and how they associate with more complex syndromes. So you can see this is, quite a busy slide, but what we're looking at is those vascular tumors in simple, combined, which vessels, and then their associations with syndromes. And so on the back end, there's a lot more detail that goes into really specifying the vascular lesion that you have. For vascular tumors, it's a proliferation of the blood vessel. It can be benign or malignant, and it can cause clinical complications like pain, disfigurement, as far as organ dysfunction or clotting derangements. With a prevalence of 4 to 5%, we know that infantile hemangiomas are the most common benign lesion we see. However, some of these lesions can be more of an intermediate risk, some being locally aggressive, others that are known to metastasize, and then it goes all the way to very high or malignant risk, like our angiosarcomas. We certainly wanted to spend more time on infantile hemangiomas today based on their frequency. As we said, it's the most frequent benign vascular lesion, and they could be superficial, deep, or both. Some present with a flesh color, and others are more of a beefy red with a shiny surface. We find them more often in premature infants, those that are low birth weight, Caucasian, and female, but they can certainly be seen in all. Most commonly, they find them in the first few weeks of life. Some parents will tell us it was right there from birth. Others will say 2 to 3 weeks later. Up to 20% will have more than one lesion. 60% of the time, they're on the head and neck, a quarter of the time on the trunk, and around 15% on extremities. And like we said, about 30 to 50% can be evident right from birth. Sometimes it looks like a bruise, kind of an ecchymotic area. Other times more of a spider vein or telangiectasia. Infants with 5 or more are at increased risk for having hemangiomas on their internal organs, namely the liver. They go through very specific 3 growth patterns. We have the proliferative phase, which starts and it goes through a rapid growth period from roughly around 2 to 3 weeks up to the first 6 months. We see the largest growth change over the first 3.5 months, and then it goes into what we would say is a late proliferative phase where it starts to slow down. Involution will start around 9 months of age, but can extend as late as 18 months. And what we find is it's very individualized. You may have a 9-month-old with obvious signs of involution, whereas another patient will come in and there's no signs that involution has begun. So these are really just small targets, but it doesn't mean that each child will meet them. That phase will continue until at least 4 to 5 years of age. It starts to involute from the center. So you start to see a purplish grayish hue in the center of the lesion, and it will make its way out to the periphery. I do caution families, and I think this is important, that complete involution, where the lesion is flat and completely flesh covered, can take a very long time, upwards of at least 10 to 15 years. So for practitioners, I think it's important that we know that concept of it will resolve in a year is really a fallacy. And many of them, up to 50%, can have some scarring or redundant skin. So it doesn't completely go away. This is showing one of the concerns with that rapid growth pattern is that you can have ulceration of the lesion. Excuse me one second, I don't know. And so this is going through those proliferative phases. You could see again that very rapid growth starting in the first 3.5 months, somewhat slowing, and then having growth arrest starting around the 9-month mark. And I always show families that right end of the slide, that 6 to 10 years, where we go into the late phase of involution. Diffuse infantile hemangiomas are rare, but they can be life-threatening. Up to 90% of them will be diagnosed by 6 months of age. 10 to 15% will have subcutaneous lesions that may give you that 5 or more hemangiomas as the sort of warning to look inside, but others do not. Most commonly, they present with hepatomegaly or abdominal distension. And some of them can present with consumptive hypothyroidism, congestive heart failure, abdominal compartment syndrome, and liver dysfunction. This is a 5-month-old that we're currently caring for who presented with vomiting and abdominal distension. Their family initially believed that it was a viral gastroenteritis that brought them to the hospital, and on imaging, we saw these very large hemangiomas. So they can be quite diffuse. We know that they can be associated with syndromes like facies and lumbar as well. Radiographically, we usually will do an ultrasound, but you can also see them on MRI and CT, and it really kind of helps us, again, understanding the flow patterns and the voids, helping to better describe these lesions. And it's important to tell us about the relationship to adjacent structures as well. Here in the picture, we're looking at what's called a reversed halo effect, where really along the periphery is where you see the echogenic portions, and the center area being more hypoechoic. Treatment options are variable. Many patients' observation is the option that we mostly go with as they go through spontaneous involution, particularly in low-risk areas. Local therapies can be used, however, if we have concerns for cosmetic concerns, risk of ulceration, areas where there's high friction, like along the diaper. We would use a topical beta blocker like Timolol, and that could be applied 2 to 3 times a day for 6 to 12 months. And what it does is really move it through those phases a little bit faster, getting it to involution perhaps in a shorter amount of time. Interlesional corticosteroids can also be used if it was a very small and localized lesion, but a little bit deeper to the surface. And we would use doses of 3 milligrams per kilogram, which can be given for a total of 8 weeks. For more complicated or larger hemangiomas where there's ulceration, bleeding, or a risk for scarring or disfigurement, we would, again, consider the possibility of medication versus surgical. If medication is chosen, propranolol is the first-line treatment. It leads to vasoconstriction, downregulates VEGF, and again, moves it towards involution faster. It does require cardiology clearance, and usually we start at a dose of 0.5 to 1 milligrams per kilogram per day, and that's divided, mostly TID is the dosing that we use, and we slowly titrate that to 2 milligrams per kilogram per day. For infants that are less than 6 weeks of age, this does require a hospital observation, and we continue that treatment usually 12 to 18 months. And the reason why it does not stop at the 12-month mark is twofold. We talked about how some lesions will not start involution at the 12-month mark, but also there's rebound growth if you discontinue too early. If there's a contraindication to propranolol, then we can consider systemic corticosteroids, and at a dose of 2 to 3 milligrams per kilogram per day. And interferon alpha is also a possibility, but is also less used. For interventional treatments, pulsed dye laser can be used for superficial lesions. It can aid in those cases where there's more ulceration, telangiectasias, or if there was erythema that existed beyond involution. Excisional surgery can also be used. And arterial embolization is offered for very large visceral hemangiomas that have not fully responded to medical therapy, such as propranolol. And so you could see below where the embolization just aids in the resolution of that vascular malformation. And this is when it's used in combination with propranolol. So in these patients, propranolol was started. You could see there's still a matter of scarring or erythema beyond the period of involution. And in the final frame, you could see after laser how it gets more flesh colored and again has less erythema or scarring. Sometimes we need a pathologic distinction, particularly for lesions that are deeper, perhaps more flesh colored. We will do surgical resection or biopsy. I know Dr. Caton will speak about this further, but it does help us differentiate, as hemangiomas will show endothelial hyperplasia, but they are GLUT1 positive, versus some vascular malformations that are GLUT1 negative. So it can be very helpful in situations that are a bit unclear. And then again, this is just showing that GLUT stain that helps to differentiate. Moving on to Kaposiform hemangioendotheliomas, these are vascular lesions. They're not nearly as common as hemangiomas, and up to 50% are present at birth. They're often red and sometimes have a red purplish color, or sometimes they actually look like a deep purple purpuric appearance. They will also enlarge, but on the contrary, they involve deeper tissue. And so as that enlargement occurs, A lot of our patients will complain of pain and may even experience deformities. Some may have Castlebeck-Merrick phenomena without an obvious mass occurring. They occur equally in males versus females, and they are typically larger, greater than 5 centimeters. 40% of them are on the head and neck, again, 30% towards the trunk, and 30% on the extremities. If there's no obvious cutaneous lesion and you're concerned, an MRI can be performed to look for things internally, and you can see T2 hyperintense or lobular structures. Management also depends on the size, the location, any symptoms, and again, the presence of Castlebeck-Merrick phenomenon, which we'll speak about shortly. Observation is our avenue for asymptomatic, smaller lesions versus surgical excisions if it's more challenging. And again, we have to understand the adjacent structures, the defined margins, and if it's near any vital structures. Again, corticosteroids and or chemotherapeutic agents may be helpful in shrinking the lesion, which can then make it more amenable to surgery, but at least eliminate some of the pain and discomfort. You can use NSAIDs for pain, and again, to prevent some platelet aggregation that occurs during Castlebeck-Merrick. Vincristine is one of those chemotherapeutic agents which you can use weekly up to 2 months. This can help minimize fibrosis and pain. But there's a lot more focus on sirolimus, which is an mTOR inhibitor, because it's felt to help prevent platelet trapping, and it also prevents the lymphangiogenesis. So Castlebeck-Merrick occurs when there's a vascular tumor. It undergoes rapid growth, and it leads to trapping of platelets inside the lesion, causing systemic thrombocytopenia. You may also see hemolytic anemia with it due to microangiopathic destruction, very similar to, say, DIC. And they can also have consumptive coagulopathy. For malignant vascular tumors, luckily these are very rare in pediatrics, up to 2%. Things like angiosarcomas, infantile fibrosarcomas, they're very high-grade lesions. For angiosarcomas, it's typically present in the second decade of life, so we don't see it as often in our pediatric team. When it's present, it is slightly more common in males than females. And again, it's a very painful enlarging mass. Because of the rapid growth, they are at risk for tumor rupture. And if they are within the abdomen, you can have a hemoperitoneum. They're frequently present in your liver or deep tissue. And again, when we look at an MRI, we see a very T1 hyperintense and T2 hypointense lesion. Again, these are very rare, so I don't want to spend a lot of time on it, but just to be aware of those lesions. Along the same lines, infantile fibrosarcoma is exceedingly rare. It's a spindle cell tumor, very infiltrating, very rapidly expansile. And because of that rapid growth, you may see ulceration, or from compression, you may see necrosis. Metastasis is very uncommon, but when it's there, they typically metastasize to the lung. A wide surgical resection would be preferred. And if you couldn't, we would use neoadjuvant chemotherapy in an attempt to decrease it in size to allow for surgery later on. Shifting gears to vascular malformations, these are classified into 4 categories. We have simple, combined, and then malformation of major vessels and malformations with other anomalies. And then again, looking at their flow patterns to further subdivide them. Genetics is very important in helping differentiate these. We know they're most commonly associated with variants of MAP2K and PIK3CA. Most of them are somatic variants. Occasionally, there may be a germline mutation. For our simple malformations, they're divided into capillary, lymphatic, and venous malformations, arterial venous malformations, and arterial venous fistulas. For capillary malformations, the port wine stain is by far the most well-known. It may also include things like cutis marmorata, and then your nevus simplex or salmon patch, which are frequently referred to as a stork bite, or an angel's kiss. They may be a flat pink or red blanching lesion, usually has a very irregular border, and mostly poses cosmetic issues, but there can also be very progressive thickening of the skin where you really get a nodular fibrovascular lesion. Sturge-Weber syndrome in particular involves at least one or many of the trigeminal nerve distributions, V1 to V3. It may be unilateral or bilateral, and we know that it's associated with GNAC gene. Periocular lesions can be associated with glaucoma, so we need our pediatric ophthalmologists involved as well. The microvasculature of the meninges can be impaired, so it is important that we evaluate the brain. The sequelae of involvement include seizures, hemiparesis, neurologic deficits. And it could be associated with syndromes like Sturge-Weber, where you have the capillary malformation. It also involves malformations of vessels in the brain and or eye, like we spoke about. Klippel-Trenaunay syndrome can also have capillary malformations, but it also has abnormal soft tissue and bone overgrowth. It's usually all along the same limb in association with lymphatic malformations and varicose veins. And Parkes-Weber can also be associated with AV fistulas and, again, abnormal growth of the limb. It really does take a multimodality treatment for these, including things like lasers, sclerotherapy, surgical resection in our medical treatment. Again, just really highlighting the need for multidisciplinary care. Capillary malformations are typically treated with pulsed dye most frequently. And again, they've modified that so that you can increase the pulse duration. They'll use cryogen spray cooling to try to increase fading, but you may still see some thickening of the skin. The biggest complications are dermatitis or pyogenic granulomas. For lymphatic malformations, this is our second most common type of vascular malformation. It's a low flow lesion, and we see dilatation of the lymphatic vessels. It's usually classified by the size, by macrocytic, microcytic, or mixed. Macrocytic tends to be in the cervical facial or axillary region. 90% of them are present before age 2. And the contrary of those smaller lesions, we usually see those along the extremities, trunk, and axilla. This is a macrocytic lymphatic malformation, which we would refer to as a cystic hygroma. It's large, skin-colored. It may be translucent or spongy. They rarely regress on their own. We do see increase, and I know Dr. Caton will show a great picture of this with infection, trauma, or hormonal changes. They tend to be asymptomatic, but you could have bleeding or inflammation into the lesion. Again, we spoke about them in KTS. Up to half of them are of a larger size, maybe associated with Down syndrome, Noonan's, or Turner's. And then indications that we have to treat would be recurrent infection, hemorrhage, disfigurement, or compression of structures nearby. For complex lesions, again, interventional treatment may be offered. Sclerotherapy in particular causes irritation to the vessel, which increases permeability and then allows for drainage and lymph flow and thus shrinking the lesion. Sirolimus has also been shown in this case. And so just very briefly about sclerotherapy, it's the injection of agents into the skin near these abnormal veins and cysts, where we can then get a higher concentration of medication. It will irritate the vessel, again, leading to that permeability and allowing things to drain, but also allowing the medication to get in. And typically afterward, there may be some swelling for 1 to 2 weeks, which can lead to some more pain and physical activity limitation, but ultimately helps with the resolution or improvement of the lesion. And many patients will need to do it more than once within a 4 to 6 week interval. Here you could see the injection of the contrast in black, followed by that sclerotherapy where it now turns white. And you could basically see it starting to make its way outside of the lesion, and again, seeing the lymph drainage improve as it heals. Venous malformations are the most common type of congenital malformation. It's a slow flow lesion. Again, it's clusters of veins and venules. It's present at birth, but can also come later. It's a deep blue discoloration. It's usually very soft and compressible. And the most common symptom that we see is pain. Larger lesions can also have intravascular coagulopathy. Here is a venous malformation of the forearm. And what you could see is it's really a very slow flow tubular lesion. And it's also very compressible. So the bottom structures are pictures. You can see the compression of the vessel. Again, letting us know that this is more of a venous lesion. Again, very conservative treatment if possible. Things like compression stockings, a pain regimen. If there's any thrombosis, we can consider anticoagulants. And surgery, if there was a small area, that could be excised. And in particular, if it was a larger lesion, having very well-defined margins, understanding the structures nearby. Arteriovenous malformations, or AVMs, as we typically call them. It's a shunt between your artery and vein. It's by bypassing the capillary, we are now leading to a high flow lesion. They're usually warm, a bluish purple color. You can feel a palpable thrill at times. The complications include bleeding, ulceration, and more significant locations can have congestive heart failure or tumor necrosis, or tissue necrosis, excuse me. Again, certain syndromes are more likely, Parkes-Weber syndrome or capillary malformations with AVN syndrome. Looking at it on imaging, usually ultrasound, we'll see this bidirectional blood flow with a high velocity and low resistance. And so they almost report it as spaghetti-like patterns within the tissue. MRI is very important as well, so we could see the cluster of the arteries and veins using MRA, so we could see the feeding vessels, or CT angio. I just want to speak for the last few minutes before I switch to Dr. Caton, but the importance of genetic associations have really come to light. Using things like next gene sequencing helps us to understand the mutations that are causing the lesions and are therefore targetable at times, particularly PIK3CA, MAP, again, using things like mTOR inhibitors. It's really an evolving field for vascular malformations. As an oncologist, it's very similar to our chemotherapy that's really looking for inhibitors that can be repurposed for vascular malformations. And again, things like the bottom right, alpesolib, that we now know is a targeted agent for PIK3CA, has been used quite a bit in our overgrowth syndromes. We're looking to, again, use medications very similar to chemotherapy, mTOR inhibitors like sirolimus. We obviously don't have a ton of clinical trials in this regard due to the numbers, but that's definitely where the field is moving, is more research in regards to these targetable agents. Again, this just talks about the role of PIK3CA and how there seems to be mosaicism in how you present. There's many different ways that the mutations can grow. Again, the related syndromes that we're seeing in response to overgrowth, vascular anomalies, or malformations. An alpesolib in 2022 was released for PIK3CA. We've had some success with patients with overgrowth syndrome in our practice, with reduction in the size of the tumor. And again, sirolimus. There are some, as you can see, rather recent studies looking at their effects on slow flow malformations. So I won't get into great detail to leave time for Dr. Caton, but again, things that are on the horizon for us. And so I'm going to turn it over to Dr. Caton, who's really going to help discuss the role of the multidisciplinary team and the services that we have here at K. Hovnanian.
Thank you, Dr. Scarbo, for that very comprehensive overview, and we're very grateful Our whole teams are very grateful to everyone who could join on this webinar today. We know that it requires a little bit of sacrifice to spend some of your midday hour. The good news for you is that you're going to get all of this information and education. And the good news for us, as I told Dr. Scarbo, is we just have to be just one level more interesting than your tuna salad sandwich, and we're all good. So as the surgeon on the team, I want to bring into the discussion the nuts and bolts of how we have forged a comprehensive program that aims to be a destination for care for these conditions. And one of the things that you have hopefully gleaned from Dr. Scarbo's talk is that vascular malformations are a scenario that really commands the full network of resources of a children's hospital. We're very grateful that we're able to provide throughout the HMH network these resources. We have our colleagues at Joseph Sanzari in Hackensack, Dr. Shin in dermatology, Dr. Kensler in surgery, and many others who are able to provide some of these services in the northern part of New Jersey. But our task in the southern part of New Jersey was to provide a destination for families who had no other ready choice except to seek care out of state. And there's a good story that has led to the founding of our clinic with respect to that. Our clinic is called the Megan Schulman Vascular Anomalies Clinic for reasons we'll show you in a moment. And it's a scenario, an opportunity for us to have families come in and be seen by multiple disciplines, not only on the same day, but at the same time. Our model is for full multidisciplinary visits where you don't have to get shifted from one wing to another. All of your specialists sometimes see children collaboratively. We have the pediatric hematology team, pediatric cardiology, and pediatric surgeons. And because we're based at K. Hovnanian Children's Hospital, we have ready access to an array of other specialists, including in some of the cases, I'll show you the need for collaboration with craniofacial and plastic surgery. For conditions that are going to require laser treatment, we will have partnerships with dermatologists in those conditions. Next slide, please. This is the ribbon cutting of our multidisciplinary team. You see some of those on some of us on the webinar are featured in this slide. Myself, Dr. Harpreet Paul to my left, and Dr. Jessica Scarbo on the right side of the slide. But featured in the center is the Shulman family, who were very generous in being benefactors to launch this clinic. Next slide, please. This stemmed from a real life story of Megan Schulman, who grew up right smack in the center of New Jersey, in Freehold, New Jersey, and had a complicated vascular anomaly for which she received care throughout her life. But given the geography and the resources that were available at that time, her family had to seek care essentially exclusively out of state. So it was a quite challenging time for the family. Ultimately, Megan passed away from complications of her condition, and the family has very generously helped us to launch a clinic in her memory. Next slide, please. Dr. Scarbo presented, and I will reinforce some of the classifications that have come out of academic work regarding how do you approach these lesions. I want to bring this really to the boots on the ground level of how do we partner with pediatricians to figure out what to do. This is a classification scheme proposed by Francine Bly, who's a leader in the field at NYU. But when a child is sitting in your office, it doesn't really give us much traction to talk about proliferative versus static. So I prefer this because this is what parents say to me. Is my child's lesion going to go away? And everyone is looking for either yes or no. And the reason why we feel it's important to have a clinic with resources and continuity is when we see a baby with a vascular lesion, sometimes we know the answer to this question, but a lot of times we say, we don't know. We don't know yet, but we're going to know. And we need all of our talents and specialties, but we also need a third axis, time, to follow this lesion and see what happens. Next slide, please. This field obviously became really turbocharged with the opportunity to treat many babies. For those who have infantile hemangiomas, now we have a well-coordinated system where a family can come to our clinic and be cleared by cardiology and start propranolol and have attention and discussions as to surgical options, essentially all at the same time. This has not been a long-standing fact in our collective fields. This really came to light after this 2008 paper in the New England Journal of Medicine. It's very exciting because this has all come about and grown essentially in the course of the careers of us and everybody who I believe is on this call. So this is all new in our collective fields. Next slide, please. I'm going to show you some cases that we've actually treated just over the last several months. This is an infant who came to us with the configuration and color of a port wine stain. So our team was able to recognize, put together the collective associations about this and work up the child for Sturge-Weber syndrome, which is the association. Next slide, please. This is a case from just a few weeks ago, but the infant presented actually with stridor, and so there was actually a medical condition that necessitated a quick workup, and everybody noticed this intensely large lesion on the back of the scalp of essentially a newborn. There was some genuine uncertainty. What do we call this? Is this a port wine stain? Is it a hemangioma? The stridor issues took precedence. And next slide, our colleagues at the Children's Hospital in ENT were able to do a laryngoscopy, bronchoscopy, and recognized that there was actually a lesion causing the stridor, and it was a subglottic hemangioma. And because of the severity, this child was treated in our ICU and immediately started on dexamethasone, and then once cleared, propranolol. And the child's condition improved from a breathing standpoint, but what was most noticeable was on the next slide. This is what everybody saw. This lesion that everyone was calling a port wine stain after initiation of propranolol actually began to fade dramatically. So it may be that this is a variant of infantile hemangioma responsive to propranolol, both medically and cosmetically. So it was very exciting for our team. Next slide, please. And again, these are actual cases that we've worked through over the last several months. And in this case, this is now a toddler that I've been following for several years because what you see is this brings together the meeting of the minds between hematology and surgery, and in this case, a very heavy lift from radiology. This is an infant on the left that presented with essentially a hunchback. There was a large lump on the back, on the nape of the neck, everyone was concerned, could this be a tumor? Do we need fast action? But we felt this, and physical exam, this is an honest assessment of what we do in our clinic. It was squishy. It was squishy, and we know it was a blood flow containing lesion. And the imaging confirmed that it wasn't a cyst. It was a blood flow containing lesion. You can see the white enhancement on contrast MRI. And this wasn't a kind of external hemangioma that looked strawberry red or was visually jarring, but everyone could feel it was there. But the family was not in really a position to start any therapy. And we all came to an agreement that, wait a second, this is a large thing on the back of the neck, but it's not actually causing any medical distress to the child. So we determined that we were going to watch it. The child had a second lesion. Next slide, please. In the axilla. I'm sorry. Here we go. This is the lesion on the left at birth, and on the right just a couple of months ago. And the child is now about 4 years old. The lesion is about the same to a little smaller, but you can't see it anymore on physical exam. You can't detect it because the child has grown around the lesion. So it's not an expansile or proliferating lesion. It has no behavior consistent with malignancy. So we've been very happy, and the family has been extremely happy to just follow this over the years. Next slide, please. The same infant had an extremely large axillary mass that you see on the left. And now with growth of the child, that same mass has regressed. It's consistent with a slowly regressing infantile hemangioma. And what would have been in infancy a cosmetically disfiguring operation, and dangerous as well because it's along the axillary blood vessels, now has been averted by our commitment to maintain follow-up with these families. And we built a trust, and the family was content, actually very thrilled to monitor this over now. I think about 3 years together, and now it's not even noticeable, only noticeable on MRI on the right, not on physical exam, barely. Next slide, please. This is a child who brought an intense number of ethically charged discussions, because this was a newborn in 2022 with a lump that you see on the left, and the lump was directly behind the nipple areolar complex of a newborn girl. Everybody was worried about it, but we thought it was a hemangioma. And you see the collaboration with radiology is needed in real time, because with these kinds of lesions, we always ask for ultrasound with Doppler. And you can see, if done by a capable center with pediatric radiology, everyone knows the waveforms to look for. And you can see that there's blood flow permeating this lesion. So both clinically and now sonographically, we were convinced this was a hemangioma, but it was cosmetically disfiguring to the nipple. The parents did not want to start any therapy. So we determined we were going to closely monitor this. So the next slide shows actually a year later in 2023, and the child is bigger, but the lesion is the same. So now I said to them, well, you really need to think about therapy, because we don't know how this will disfigure her breast as she grows. And still, the family, who was very, very amenable to close monitoring, was not interested in medical or surgical therapy. But we can see the same degree of measurements of the lesion and the same blood flow. The discussions continued into 2024. Next slide. And the lesion is the same. So at this point, after more discussions, we determined this is not regressing. And we've been calling this a hemangioma. And this is, you really have to have a degree of humility as physicians who treat these lesions, because we want to promise parents, oh, don't worry about it. It's going to be great. It's going to go away. And I had to acknowledge quite humbly, we've been calling this a hemangioma. I really still think it is, but it's not going away. And as she heads towards pre-puberty, this will be visually jarring on the breast. So the parents consented to having it removed. Next slide. So this is what it looks like. It's not big, but it was soft and squishy. It sure looked like a hemangioma. And we were able to do a circumareolar incision with a very nice cosmetic result. It's actually almost imperceptible of a scar at this point, now that she's healed. But interestingly, we still didn't really know what this was, because it didn't regress one bit. So we gave it to the pathologists, obviously, who, next slide, recognized that this hemangioma had undergone something called fatty replacement. So although we like to say, oh, your child's hemangioma will go away, it doesn't actually vanish into the air. So the body has to do something with that tissue space. It may shrink a little or a lot, but it also may be replaced by scar tissue or fatty tissues. And you can see the fat globules at the bottom center of the histologic diagram. Next slide is a little closer up. And you see it consists of fat globules that have come in and replaced what was previously just a network of capillaries. The pathologists went to what Dr. Scarbo introduced in her slides, something called the GLUT1 stain. And you see the brown staining of the lining of every blood vessel. That's the GLUT1 immunohistochemistry, which is pathognomonic for infantile hemangiomas. So it's an infantile hemangioma in a 4-year-old that never regressed because it had undergone replacement with fatty tissues. So the mass remained, although time had passed. Next slide. This is an interesting lesion that I'll show you, and I wouldn't be surprised if 1 or 2 or 10 or 20 people who are on this call today may have actually seen this child, because this family came to us saying, we have switched our pediatricians 8 times. They went to every pediatric practice in Monmouth County saying, why can't anyone help our newborn's diaper rash? So I certainly would have thought the same, that this was just a terrible, terrible diaper rash that then ulcerated and bled. And this was in a 1-month-old. So this was extremely concerning, obviously, for the parents, and it's right by the anus. So with every stool and with every wipe and every diaper change, this was a big problem. They came to our team and we took a look at this and we said, wait, this is not a diaper rash. And here's where the multidisciplinary approach is really beautiful, because we had all eyes on this essentially immediately. And everybody said, that is no diaper rash. That's a hemangioma. And it's a hemangioma that's at the anal verge. It's ulcerated and it's bleeding. So it was doing all of the things that necessitate immediate pharmacologic therapy with propranolol. So a cardiology evaluation happened immediately, and the infant was on propranolol in a few days, and it's essentially gone. And the family's happy because the child no longer bleeds with every diaper change. So that sometimes that recognition, that glimmer of recognition by a team of experienced clinicians um, is all that it takes. And I have genuine sympathy for the 10 pediatric practices because I think anyone would have treated this as a diaper rash. And next slide, please. When a child has multiple hemangiomas on the skin, we usually assess for visceral hemangiomas. And here you see liver lesions in a child who's been under recent observation with us on the left from about a year ago. And we follow these with ultrasounds, again, with heavy involvement and input by pediatric radiologists. The image on the right was from about 2 weeks ago, and the liver lesions had spontaneously involuted. This was sort of a low-level liver involvement that was picked up because the child had about 5 cutaneous hemangiomas. That was the reason for the workup. But some come to us with known or much more diffuse liver involvement. The next slide shows the child that Dr. Scarbo initially introduced to you a few minutes ago at presentation on the left, with more liver lesions than our radiologists could count. And then after 2 months on propranolol, we see on the right some regeneration of hepatic parenchyma, a reduction in the number of liver lesions, and a gradual reduction in the size. So this is a child who's going to remain on propranolol for a long time, as long as it's tolerated, and we'll continue to monitor these by ultrasound. And when real precision is needed, we bring them in for our pediatric sedation specialists to do a sedated contrast MRI. And that's what you see in these images. It gives us real precision in the blood flow and the measurements. Next slide, please. This is another lesion on the back that never went away. And so we did a little bit more workup, because this child is already 6 years old. And you can see on the left panel, it just looks like a bright white area in the skin. So on clinical grounds, we were willfully vague as to whether this was a hemangioma or an arteriovenous malformation. And the child was doing really well with it, even though it's about 6 by 6 centimeters, like a pancake on the back. But now the parents are a little bit more concerned because he's thinking about playing football. So we said, maybe it's time to deal with this. With contrast MRI and MR angiography, we determined that this is more complicated than an infantile hemangioma. And the panel on your right shows, actually, you can see a white sigmoidal shaped stripe showing that there's major blood vessel connections, not only to the azygous veins, but potentially to the spinal arteries. So this is a situation where we would take a true multidisciplinary approach with input from embolization folks, with interventional radiology, as well as neurosurgery to address any vascular communications with the spinal arterial system, followed by a collaborative plastic surgery approach to take off the cosmetically apparent area on the back. Next slide, please. We have also been treating children with hemihypertrophy symptoms such as Klippel-Trenaunay. This is an 8-year-old male who was followed sporadically by specialists in many different parts of the state without sort of bringing it all together in one place. An MRI on the next slide shows the limb discrepancy. Next slide, please. There we go. So what we can see on the right-hand panel is that the patient's right thigh, of course, this is the view is the patient looking at you. The right thigh is to your left, and you see that there's a tremendous soft tissue hypertrophy where the cursor is seen on on the patient's right thigh. So the family had been asked to think about all kinds of things over the years, because this is already an 8-year-old child. Should there be some sort of commando excision of the hemihypertrophy and some sort of medication or embolization? But all of the while, from birth to 8 years old, they kept saying, you know what, this doesn't bother anybody, except for one problem. He really, really, really loves to play soccer. So the next slide shows the soccer is fine, except Klippel-Trenaunay comes with a limb length discrepancy in this child. You can see the right leg is longer than the left. So here is a condition that really commanded Children's Hospital approach, because the truth of the matter is the family wasn't in need of any kind of embolization surgery, sirolimus. They didn't really need any of that. They just wanted him to play soccer. And we brought to bear our team of pediatric physical therapists, orthotic specialists, who recognized that over the years he'd been prescribed some braces that he wouldn't use because of embarrassment with his friends. But we were able to devise for him some custom inserts that were able to be put in his Nikes, and he now plays soccer in regular looking sneakers with everybody else. And they were totally happy with this approach. And I was just so grateful we were able to provide that. Next slide, please. We've seen in this current year of respiratory illnesses, we have seen several cases of strep infection that have brought to light lymphatic malformations that were previously unrecognized in children. I don't know the mechanism. There's only about one case report in the medical literature. We had 2 this winter. A strep infection, and then a week later, a massive ballooning enlargement of a previously unrecognized lymphatic malformation. This is a child that presented to us with a ballooned out lesion, soft and fluid filled, in the right flank, over the musculature of the right upper quadrant of the abdomen, seen on ultrasound to contain fluid, and on the right-hand side of the screen on contrast MRI, we see this is fluid filled, not blood filled. So it's a lymphatic malformation. And with passage of the strep infection, it's actually spontaneously gone down quite a bit. And these can be dramatic sometimes. Next slide, please. This is, I think, one of the last cases we'll show, but this child presented to our emergency room with a massive abdominal distension and an ultrasound that showed a 9-centimeter lesion in a 2-year-old, and everybody was very worried about a Wilms tumor, and the oncology team descended rapidly on this child, but everyone said, wait, this is a series of fluid-filled spaces. Next slide, please. The rapid workup owing to the degree of concern led to this CT scan, and you see water balloons in the abdomen. Next slide. Confirmed on MRI. Next slide. Cystic spaces. This was 2 weeks after a strep infection. So we determined this was a lymphatic malformation. It began to regress. At the 2-month follow-up by ultrasound, that massive lesion was down to 3.5 by 2.5 centimeters. And next slide, at the 3-month follow-up, it was just barely bigger than a golf ball. Owing to the patience of our team, the availability of radiology, we did not have to do a major laparotomy to remove this. And I'm not sure if there's anything left at this point to remove, but we'll continue to follow this child who's well now. Next slide. So those are some of the conditions we've treated just in the last few months. We are just super grateful for this opportunity. Dr. Scarbo and I are very proud of the teams and the disciplines that have come to help in this endeavor and to help families get one-stop shopping. We would be very happy to take time to hear questions that might have been posed on the chat. And on behalf of both of us and our teams, we want to thank you for taking this time and hope that we have proven more interesting than your sandwich. Thank you.
Dr. Keaton, Dr. Skirbo, that was a truly excellent presentation. And thank you so much for the time for us to learn it. Just to jump through the questions, starting with our first, what sclerotherapy agents are most commonly used and the side effects of these agents?
So for the side effects, we're really looking at, again, some additional scarring and then redness. So we know that certainly after the treatment is given, there is some swelling to the area. So sometimes that will just require a bandage or compression. But again, we know that it may limit their activity for a short period of time, but they're all used very safely. And so those are things that, again, we would use with our dermatology team to come up with the best recipe for the child.
Diana shared a really personal anecdote of her son's experience with hemangiomas. And she mentioned that unfortunately, due to all the laser surgery, he has extremely limited vision in left eye due to the optic nerve damage. Have you had any experience with regeneration of the optic nerve in any of your patients?
I think given the recent formation of our multidisciplinary program, I don't know that we have the years of experience in tracking patients with ocular involvement. We are pleased to have pediatric ophthalmology joining into our multidisciplinary clinic imminently. So what we'll be able to offer is the prospect of sequential eye examinations tailored to the nature of the vascular anomaly if it is something that affects the ocular system.
So another question we had is, if we see one of these lesions, like a Sturge-Weber or hemangioma, who should we be sending them to?
So that's a great question. And again, there's a number that's shared on this screen. We have our vascular malformation nurse navigator, Karen Casey, who would be fielding those calls. So if you have any concerns, if you're not certain what you're seeing, or if you are sure, just give a call to that number and we can help to decide if you need to come to the Vascular Anomalies Clinic with the multidisciplinary approach. Some lesions, we may say you could see, hematology first, but Karen is wonderful at navigating that process. So the number below, the 848 number, is a direct contact to that clinic, and we can help with that information. So I would start there. That is the whole reason for this clinic, is, again, having that one stop. All of the specialists will have eyes on that and decide the best approach for your patients.
Thank you. And from Jayshree, does the strep infection cause the lymphatic abnormality, or the abnormality just come to light with the strep infection?
My inclination is to think that the strep infection causes a secretion of fluid in the lymphatic system as a secondary effect, as an inflammatory effect. The cases that have been described in the case that I could find in the literature and the cases that we've treated here had the enlargement of the lymphatic malformation initiating about 1 to 2 weeks after the identification of the strep infection. And these were thought to be regular strep throat cases, followed sequentially, chronologically, by later expansion of the lymphatic malformation.
Great. We also had a question of, do you either have experience with children with Mongolian spots? Does that ever lead to any need for treatment? And is this a risk factor for any other conditions in the future?
So those are more of a nevus that forms. Those are not necessarily vascular in nature. So they aren't particularly seen at the Vascular Anomalies Clinic. And we usually see that those may, again, as the child grows, become more prominent. But again, since those are more of a skin nevus, they're likely to be there lifelong.
Thank you. So I think that's all the questions we've received so far. Again, I want to thank you, Dr. Caton, Dr. Skirbo, and Dr. Paul for also joining for their intro. But thank you for the presentation. It was truly exceptional, and I appreciate all those who joined, as well as the NJAP, for partnering with us for this opportunity. Thanks, everyone.
Thank you. We look forward to working together.